Hi everyone, welcome to Mental Health Monday, live with Dr. David Rosmarin. I'm actually very excited about this topic. It's like I've actually read a lot about it, and I find it very fascinating because I think that a lot of people really don't understand what OCD is in general, and definitely what scrupulosity means. So I'm really excited to learn more about it from, Dr. Rosmarin did like so much research and is one of the leading researchers on the topic. So I'm really excited about this. Just waiting for him to join, and then we'll add him. Hi, Bruchy. So I listened to some podcasts on this topic, and I was reading some articles about it. Hi, Miriam. So I was reading a lot about it, like this was months ago, and then we were just discussing who the best person to talk about it would be, and I think I was talking to Rachel Tuchman about it. Actually, I know I was, and so he was like the first person that came to mind for this topic, and I'm very excited about it because he's actually did a lot of research in OCD, but also in religious studies. So there's a lot of insight there. Hopefully he will be here soon, and then I could just stop rambling. I hope everyone is having finding a new normal, and I certainly am trying. After the holidays, it took a while. It's still taking a while, but yeah. Sorry I'm rambling. Hopefully I won't be for very long. Let's see if he is on. Not. Oh, here. Yeah, Center for Anxiety is here. So wait a few moments.
Hi.
Hello.
How you doing?
How are you? Good, thank God. How are you?
I'm doing okay.
Oh, you're so fancy with your social distancing tie.
You got it.
There's that meme going around, like, who else puts on perfume before the live, even though nobody's gonna.
It's
Did you see
funny.
that?
But I am also wearing pants though,
Oh, that's good.
which is good.
So I was just saying before you came on that I'm really excited about this topic, and like months and months ago, I
Right.
read a lot about it and started getting really into learning more about it. And then we had talked about it, and you agreed to do this live. So I'm really excited that we're finally doing this, because I think it's really a topic that people don't really understand a lot about.
100%. Lots of misconceptions about it.
So
But what's also
yeah.
good about it is that you asked me to do this before COVID-19,
Mm-hmm.
and this has nothing to do with COVID-19. And I can't
I know,
remember
I'm
the
so
last
excited.
time that I took an hour and didn't speak about COVID-19. Just to speak about something
It's
else.
very exciting.
I mean, it's kind of anxiety and like OCD and mental health, and I guess it's kind of, I'll probably mention it at some point, but it's kind of nice to
I
get a
mean,
break.
I'm sure that people are feeling. I'm sure religious scrupulosity is coming into play when, with not praying in a minyan, or like not doing certain religious practices that they're normally would feel very guilty about. Like, I don't know if like that guilt and shame. I mean, maybe you should start from the beginning and then we can,
That's
go
interesting.
there.
That's an interesting. It certainly is possible. We haven't been seeing a lot of that in the office, but it's certainly possible that some people are struggling with it. If anything, what we're seeing now is that a lot of our anxious and OCD patients are actually doing really well. In fact,
I heard that from a lot of therapists.
I wrote an article about it last week in Prevention Magazine. So, and I got a lot of feedback. A lot of people wrote in and said, yes, that's exactly what's happening. I mean, it's not for everyone. I want to be clear. Some people who have pre-existing anxiety or OCD, they're struggling a lot, and that's to be expected. But many people are doing a lot better. I think it's because a lot of people have prepared for it, and they know that facing anxiety, tolerating uncertainty at high levels is really the way to go. And that's what everyone has to do today. No one knows, no one knows what's going to be.
What I notice is people are feeling a lot less, of the shame and stigma around it. And people feel much more open, saying, I'm not okay. I think that's really helpful.
That is definitely.
But you
would
know,
okay.
Because you're in the middle of this whole research study.
Yes, we just submitted our first manuscript about it tonight, actually. So but we're not speaking about COVID-19. We're speaking about religion and OCD.
Yes. All right, let's get to it.
Speaking about scrupulosity, and scrupulosity being religious OCD. And I have some notes here, so I'll just kind of get started. So I remember when Rebecca, when I first went into mental health, people would say to me, this is however many decades ago, people would say to me, oh, you're a religious person? Like, how could you become a mental health therapist? Don't you know religion makes you crazy? And I would just brush it off, like, leave me alone. Like, I'm trying to help people in at least in my community, and maybe I'll have a broader impact. Like, leave me alone. But I always found the question really strange because I never personally saw, I know that there are people who are from religious communities who struggle, of course, and that's, of course, the case, but I never saw a causal relationship. If anything, it seemed to me that many aspects of religion were potentially helping down, helping people to feel less depressed, less, more connected to something, having a sense of hope, meaning, purpose. And that's what the research has shown. So I always thought it was a strange topic, but when it comes to religion and OCD, people still have this misconception. In fact, some people think that religion is OCD, and in certain aspects of religion do look like it. I'm not an expert in world religion at all, but in the Catholic religion, and here I'm reading off my paper in front of me, people pray something called the Rosary, and they take out a rosary, and there's a crucifix, and they make a sign of a cross, and then they pray the Apostles' Creed, which is a 109-word prayer. And then they go through these beads, and then they go through all the little beads, and then they get to a large bead. And then they say, Our Father, which is another prayer. And then they go to 3 smaller beads, and then there's a chain, and then there's another prayer that they say. And then it depends on which day of the week. Is it a Monday or a Saturday or a Tuesday and a Friday? And then there are these different verses that they say. And people pray this multiple times per day when they're feeling anxious, or just in general. In the Buddhist tradition, there's something called a prayer wheel. Have you ever heard of a prayer wheel?
No.
Yeah, I don't mean like American Buddhism, like the modern version of it. I mean like, real deal Tibetan Buddhism. Not that Americans can't be real Buddhists, but it is different culturally. You have these very intricate cylinders that have sometimes thousands, even millions, sometimes the really intricate ones have all these mantras that are written in Newari, which is like a cousin of Sanskrit, and they're supposed to be rolled across the fingers. They roll them or across the forehead, while a person has these very precise thoughts, these meditations of what exactly they're supposed to be thinking, and it's been done at specific times of the day, specific times of the year. These are very clear rituals that they have. And in the Jewish world, which I imagine most of your folks are participating or are from, just look at the custom of washing hands in the morning, right? A two-handled cup, and you fill it with the right hand and transfer to the left hand, and then pour again, and then pour again, and then pour again, 3 times or 4 times or whatever, depending on the custom. Exactly 3.8 fluid ounces of water, no less, on each pour. So, like, is this religion or OCD? All of these and other things. And if you look at OCD, it's a very heterogeneous disorder. Many subtypes, lots of different things. Patients with OCD, sometimes they get really obsessed about order, and it has to be in a certain exact way. And sometimes they'll count. So they'll count, and then they'll stop, and then they'll count, and then they'll stop, which sounds a lot like what we were talking about before. How is that different than the rosary? And other people have this feeling, they have to feel just right. So when it has to be done in a certain way. I had a patient who would not walk through a doorway into their home or into, any room unless they felt just right. And if they didn't, they would go back and they would touch the lintel, touch the sides of the door in order to get a sense of, oh, I feel just right now. And then they would walk into the room.
We have kissing the mezuzah. Yeah,
that too. How is that different than a prayer wheel? I mean, how is that different than that form of OCD? Why are these?
That must be torture with COVID, with with not being able to touch surfaces, and you're going and like before that everybody stayed in their homes, and they were just told to not touch things. I'm sure that was it. Very difficult.
Could very well be.
Or maybe I just don't understand OCD.
Well, OCD people have, these thoughts in their mind. Oh, we'll get to it, but sometimes people have obsessions and compulsions around washing. So if somebody has it in their mind that they have a virus, like I don't mean COVID, I mean they're really concerned in their mind, but they don't really potentially have it. It's the excessive. They have the thought in their mind is really excessive to the real reality. And they're sitting there washing their hands all day. We're talking about 4 or 5 hours a day potentially, until they're red and raw, and actually at a higher risk for getting for getting a virus because they get rough. How is that fundamentally different than religious hand washing? So you really have to define your terms. And when it comes to, there's religion and then there's OCD. You asked what OCD is, so I'll skip to that. OCD is recurrent, unwanted, is O and then a C. So obsessions and compulsions. And the O, the obsessions, are recurrent, unwanted thoughts that are here, and they cause a person distress, and they're trying not to have them. And the compulsions are actions that they do, activities that they do over and over again to get rid of those obsessions, to get rid of the stress. So if someone has to feel just right, they'll do a certain ritual in their head or with their body in order to feel just right, and then they'll walk in. Or they're counting. I have to think of the number 3. I have to count to the number 8. And then they'll actually count. That's the compulsion in order to feel better. Same with the hand washing. So the whole thing about OCD is that it's driven primarily by fear, and it's a repetitive behavior it's not only primarily, it's purely driven by fear. Religion isn't like that. Religion is driven, at the best of times, but what real religion is driven by an intent to connect with something sacred. The purpose of the rosary, prayer wheel, washing one's hands, is ultimately to connect with something which is greater than just the physical world. It's a culture-bound way of relating to something which is greater. So based on these two definitions, normative religious practice is not OCD. Because when people have a thought, they want to pray the rosary, even if there's some anxiety there, that's not the main reason why they're doing it. They're doing it because they share a culture with other people, and they're engaging in certain behaviors. When people put on tefillin, the phylacteries, and Jewish, primarily men, put on, the Orthodox world, put on their tefillin in the morning. It has to be done exactly a certain way, right in the middle of the head. The boxes have to be square. It has to be black, entirely black. There's certain laws that are involved, but it's not OCD because it's not being fully driven by fear. even if a person's afraid, like, well, maybe my tefillin are this, that, maybe I am or I'm not clean while I'm putting it on, those aren't necessarily OCD, because the purpose of it is to connect with something greater. There's no obsession and there's no compulsion in of itself. By contrast, the OCD, when it comes to obsessive compulsive disorder, the main thing is anxiety. The person is being driven by it, and the only reason they're engaging in that behavior is in order to mediate their anxiety. So the other question, though, is does religion cause people to have OCD? Well, am I being clear, Rebecca? Is this clear? Did I make that contrast? As far as I'm concerned,
Yeah.
Religion has nothing to do with OCD. They might look similar, but the reason is because what we call the function of the behavior is different. The function of the behavior in OCD is simply to get rid of somebody's distress associated with their thoughts. With religion, the intent is to connect with something greater through a culturally sanctioned practice.
That makes sense.
All right. We're making progress.
Yeah.
Okay. But let me ask you this. So maybe religion and OCD are different, but maybe religion sets people up to have OCD, right? Because you're doing these practices and you're doing it to connect with something else. Well, like maybe it's a risk factor and you're more likely to develop OCD. Possible?
Well, I thought that maybe that when the rabbis, like back in the day, codified the laws, that it's a lot of it sounds like it could be coming from that kind of place.
Oh, that was the first question.
That's kind of what spurred my question in the first place.
Yeah,
I started doing all this research.
Well, I hear that, and I'll tell you why it's not the case, because maybe in certain cases it could be, but in across the board, if the motivation is to connect with something greater, that is not OCD. If the motivation is just to get rid of negative thoughts, then it would be. But to have mass cultural practice, when you have a group of people who are engaging in a certain behavior in order to connect with something, even though it might seem strange relative to normative culture, that doesn't mean that it's OCD. That's religion. That's actually what religion is.
Right. And I mean, like moral scrupulosity, like would also be kind of like, for a higher purpose.
So we'll get there. We'll get there.
Starts becoming fear.
We will get there. We'll get to moral scrupulosity. We'll get to religious forms of OCD, which is a little more complicated. And what is that? So we'll get there. We'll get there. But we're starting, Aleph, Beit, Gimel, right? Like, let's go in order. So first things first, religion and OCD are two different things. Second, does religion cause OCD? So this is the question that my people would ask me when I was in graduate school, right? Don't you know? What makes you crazy? And I always thought it was strange. And I the reason why I think they were saying it is because as a clinician, I don't know how many people here are mental health clinicians on your people who joined today. Do you have any idea?
It looks like there was a handful.
Okay, so for the handful of clinicians, we don't frequent day-to-day with people from the general population. The people who I'm seeing in my clinical practice, by definition, are people who are distressed, significantly distressed or impaired by their symptoms. So when we see religious individuals who will come into our practice, there's this illusory correlation that, the religion is related to their symptoms. But we have to step back and actually look at what's happening in the general population. A clinical sample is not necessarily the best group to make those decisions from. And that's why we really need to do systematic research. So I'll give you a little bit of data on here. Firstly, religious affiliation in the United States, 78% of Americans have some form of religious affiliation. 78%, nearly 4/5. And in fact, religion is important to the same number. More than 50% of Americans pray once per day. Yet, OCD, do you know what the base rate is for OCD? how many people in the population have OCD at any given time?
No.
So lifetime prevalence is 2.3%. Not very high. And on any given day, it's 1.2%, like 1 in 100 people. Now, it's a lot of people, but it's not that many. And religion is far more common than OCD. So we have to consider that, if religion were a risk factor for OCD, we'd probably see a lot more of OCD. But there's another thing which is important, which is that there have been probably about 30, somewhere between 30 and 40 studies, research studies done. And these are international studies, which have been done in Canada and the United States. They've been done in Turkey. They've been done in Egypt. They've been done in Israel. They've been done in Russia. They've been done in, not much in South America, but, there's been done all over the world. And looking at religion and OCD in the general population, and what we find across the board with all of these studies is that there is no relationship between religion and clinical symptoms of OCD. People who are religious are equally likely to have OCD as people who are not. If anything, they might have a little bit less depression and a little less anxiety overall, depending on which facet of religion you measure, because religion has many aspects to it. But the main point is that people don't have more OCD if they are religious. And furthermore, patients who have religion versus patients who do not have religion, their levels of OCD symptomatology is primarily the same, although their treatment isn't as effective. Treatment is typically not as effective, but I don't think it's because the actual treatment is different. I think it's because the clinicians don't know often what they're doing when they come across religious OCD. Primarily, we don't treat it as well. Clinicians aren't as well versed in how to deal with it. Many, not all, but many clinicians are not.
Can I ask you something? Would it also depend on the type of religious affiliation? Because some are more, shame-based affiliations that might.
Good question.
Like, would it depend on the type of affiliation?
Yeah, like Catholics versus Jews versus Protestants versus Muslims versus people who have no religion,
or even variations within each of the religions. Like there are certain
you won't find effect.
Subsects.
No, the research that's been done comparing different religious groups on their levels of OCD has not shown significant effects. Not on clinical levels of OCD symptoms. You won't find that. But what you do find is if you compare religious to non-religious patients, religious patients tend to have religious symptoms. Non-religious patients tend to have non-religious symptoms.
That makes sense.
And that's really how we end up with religious symptoms in OCD. Often in OCD, the obsessions attach themselves to the most important thing in a person's life. And for people who have religion, often that's their faith. I had a 62-year-old married man once who came to my office, and he was repeating his prayers for 4 hours a day. That was just the morning prayer. The afternoon and the evening were a little bit less, but still a lot. He was spending 6-8 hours a day in his prayer. And he was saying, did I pray correctly? I don't know if I did. Hours and hours mentally reviewing what he said. Did he say it correctly? Did he not say it correctly? Going back, repeating his prayers, pure thoughts. If he didn't have a pure thought, he would go back, cross it out. That's OCD. That's not a way of connecting with his spirituality. That's a way of dealing with negative thoughts, very clearly. And these cases are OCD because the beliefs are not normative. People in their culture aren't behaving this way. And they're not concerned with having a spiritual connection. They're concerned with getting rid of a thought that's in their mind. I don't know if he's a colleague, he's probably more of a mentor, Dr. David Greenberg in Israel. And he said that one of the hallmarks of religious OCD is that it actually gets in the way of a person's religion. And indeed, this person was praying for 4 hours a day. They weren't able to pray. They weren't really praying. They were just obsessed and engaging in compulsion. So one of the hallmarks is not only that it affects their distress, and it affects their functioning day to day, it affects their religious functioning, which I think is a very interesting way to think about it. Other people have thoughts about, what was that?
No, I said that's a good line. And Robin Gutman also said it's a good line.
Okay, good company. I saw another man, single male in his mid-20s, plagued by these thoughts that he had committed this unforgivable sin. He believed in God, but he thought these thoughts were so upsetting to him. He would have these bad words that came into his mind when he was reading religious texts. Sometimes he actually thought he said something that he shouldn't have said. Sometimes he thought he had done something, moral scrupulosity, like you mentioned before. He thought he had it. He thought he had harmed people, but he hadn't. He thought he had stolen their money. Maybe he charged them too much. And he was avoiding religious images, avoiding religious thinking, because it was so upsetting. Again, these are not aimed at connecting to something sacred. They're aimed at reducing his distress associated with his thoughts, period. That's the primary, if not the only motivation. It looks like religion, but it's not. The problem in these cases is that
the distress isn't really about the religion. That's what you're saying.
You might say it is, but the ultimate distress is because they're having a thought. Because they're having a thought. And by the way, that can happen in non-religious OCD, where somebody is convinced that the reason that they're afraid is because, no, really, I might have the AIDS virus, so I have to wash my hands. I'm really afraid of it. Like, maybe it's real. So somebody could say that, well, maybe it's something that God wants me to do, but it's not really sanitation and being sanitary in the first case, and it's not really religion in the second case. That's not what it's aimed at. You're not really trying to stop having the AIDS virus, and you're not really trying to connect with God. Let's be very clear. That the person is aiming to reduce their distress associated with their thoughts. That is what makes it OCD. But again, I don't know of any causal evidence, any empirical evidence at all to suggest that people with religion are even more likely to have OCD, let alone that there's a causal factor. There's certainly nothing suggesting that religion causes people to have OCD. You can blame religion for a lot of things, but OCD isn't one of them.
I mean, that's good. That's good to know.
I think it's important to know, because often people blame their faith for how they're feeling. I tell my religious patients with OCD, if you weren't religious, you'd have OCD anyway. It just would be about something else. Right?
So, I think I told you about this podcast that I listened to by Dr. Jed Sieve a while back, and he was saying how it's really important to find a therapist who really knows what they're doing with this, because right. The treatment is not trying to pull people away from their religion. It's because it's really not about the religion. It's about finding the best treatment for the issue at hand. So how would somebody know if they had this type of OCD and they needed to find a good treatment for it? How would they know that the therapist is equipped to support them in it?
It's a great question. There are two criteria that a person would get that a therapist would need to have in order for me to recommend them. The first is that they have to understand what exposure and response prevention looks like, and they really have to have a very solid working knowledge of OCD. I don't just mean somebody who's been trained in CBT, which these days is a buzzword that can mean absolutely nothing. And believe me, I review probably 50 to 100 applications every year of clinicians who want to work for my office. And between 50 and 100 applications every year. And a lot of people say they have, CBT experience, but I'm looking at the actual experiences, and it's not definitely, they haven't done behavior therapy. They haven't done exposure with actual patients. I want to know that somebody knows to do exposure therapy, not just CBT, like I said, They've treated multiple patients. They're a member of organizations that are like the IOCDF, the International OCD Foundation, or perhaps the Association for Behavioral Cognitive Therapies, ABCT. So I'd want to know that they actually know what they're talking about. They've been to workshops about it. Plus, I would want to know that they are, as Dr. C put it, religion friendly, and that they're also religion savvy. It's more than religion friendly, that they're savvy about it. They actually understand where does religion end and where does the OCD begin for that patient. Those are the two criteria.
He had an incredible line that I really never thought about it this way. He said that trying to get some, he said he was talking about like people who have issues with meat and dairy, and they're worried about having meat and dairy next to near each other because for kosher. And he was saying that the therapist that would recommend throwing away kosher, it's like telling somebody who has a fear of dirty needles, of walking through a field with dirty needles, to take a dirty needle and stab themselves with it. He said it's not logical treatment.
Putting your hand in a biohazard box, right? It's not the same.
Right. Right.
What we want to do with someone, and that's where I was going to go next, is, what do we do? How do you help patients who have religious OCD? And, when we have the patients, like you said, they're afraid of the needles, we would want them to touch the outside of the biohazard box, but they never put their hand inside. I would never ask a patient, I wouldn't do it myself, and I'm not asking patients to do it, but I would touch the outside of the biohazard box.
Right.
They might touch certain things in the bathroom, but we're not having them eat it.
Right.
Fair enough? Right.
Yeah, well, I mean, like what he was saying is you could put the dairy pot and the meat pot next to each other. Oh,
you can do a lot more than that. You can do a lot more than that. I'm telling you about something we did.
Or something like that.
So when it comes to OCD in general, obviously the treatment, and I don't know how many of your listeners are familiar, is choice is exposure and response prevention, where a patient is encouraged to expose themselves to the fear and not engage in the compulsive response. Response prevention. Be exposed to the fear and then prevent the response. Exposure and response prevention, EXRP. So, for example,
what if somebody has a trauma history, though?
Why wouldn't you do it?
I don't know. I'm just asking. If
the only one, it's more risky that the therapist would get traumatized than the patient.
Okay.
The patient, exposure and response prevention, learns to get over their fears. This is the way to do it. And even if they have a trauma history, it's not, as long as we're getting the diagnosis right, we would want to push this. When people are afraid of germs, we have them touch all sorts of things. Not now with COVID, but in general, we'd have them touch doorknobs, subway, things on the subway, things in public, staircase handrails. If patients are afraid about checking the stove, we would have them turn on the stove and leave the house for a couple hours, see if the place burns down.
I think I would be anxious about that.
Well, we got to talk. Let's say they didn't lock their door. Let's say they're afraid. Oh no, did I lock my door? Did I lock my door? Sometimes people have the hit and run OCD, where they're afraid that maybe they hit a person in their car on the way to work. They drive straight there, right? Run all the stoplights. No, I'm kidding. But they would go straight there, drive normally, don't go back ever. Drive on the highway, never going back, not looking, seeing where the person is that they hit. And we want to increase these over the course of treatment. When it comes to, and I mentioned this before, we violate OCD law, but never natural law. So if a person's afraid of the contamination, right? I mentioned that before about the biohazard box. If a patient is afraid of the electric stove, we would have them turn on the thing and leave, but we wouldn't have them do that if there are like loose curtains in the way. People turn on their stove all the time and they leave. They do it for 72 hours over a 3-day holiday, right? 3-day holiday in the Jewish world, all the time.
You just have to be safe about it and not put like a towel next to the stove.
For the 62-year-old man who repeated his prayers, so he was not allowed to repeat. In fact, we came up with a rule and we worked with his rabbi on this, that if he repeated anything in the prayers, he would stop right there and move to the next section. He would miss out on those prayers. Right? Shema, Shema, you get it. Next paragraph, V'avta, right? Whatever it is. And then moving on to the next one. For a patient who had those bad thoughts about thinking that they had these unforgivable sins, right? No confession. Once. And then that's it. No extra confession. And we might even have them think the thought. I had a patient once who their thoughts were so severe, we actually had to put out certain pictures. We actually put certain pictures in their prayer book to trigger them, and they weren't able to cancel out those thoughts. Sometimes people will avoid religious activity because of their OCD. So we'll often encourage them, kind of like Dr. Steve said, right? We're not trying to get people to stop being religious. We're trying to stop them from obsessing about it. It's completely different. So we would often encourage people. I've seen many people who don't.
So
they don't go.
asked.
Yeah.
Sorry.
Okay.
It cut off.
Oh, what I said was. Should we go to questions or?
Oh yeah, but I missed the last thing that you said.
Oh, what I said was, I don't know, what did I say? It's late. I said...
You can go to questions.
I
could watch it later.
I said when people have OCD, they have to face their fears, and religious OCD is no different. We have them face their fears. But we don't have them violate the religious law. Oh, right, that was it. People often avoid religion, and that's not helpful. Often we are encouraging our OCD patients to engage more in religious practice. But with regards to the kosher, I'll tell you a story. I had a patient who had very severe kosher OCD, extremely severe kosher OCD. And we worked with her rabbi to actually bring bacon into her house, smear it on her pots, wash it out, soap and water, and then we cooked soup for her family and everyone ate it. Nothing was hot, so it didn't make anything non-kosher.
So everything was like halakhically approved?
Totally halakhically okay and completely in violation of her OCD. Jonathan Hupper, she was flipping out. And it was great. One of the best things she ever did. She will never forget that.
Wow.
Jonathan Hupper, who's at Hebrew University, he's done a lot of work in this area. He had a very funny anecdote about telling a patient to take bacon and to put it under her pillow, to sleep with bacon. He joked that his psychodynamic colleagues had a really, really, really funny response to that one, as you could probably imagine.
Probably.
Mm-hmm. And that was her thing. I've had patients who are upset about kosher, and they what do you call it? We bought cans of crab, brought them into their house, all sorts of stuff. Another thing is family purity. That's a tricky one because the law.
I've heard that a lot.
Yeah, it's very common, and it's actually coming up even now a lot because people are home more, and so I think that is sort of somewhat even elevated for patients today. I've had patients who had such fear about maybe they might be staining, or maybe their wife is staining, or they are staining. They would actually look forward to days of separation, so they didn't have to deal with it, and it really impacted their marriages. Very, very, sad, very sad. In those kinds of cases, we want them to think in their mind. I mean, of course, we wouldn't have them violate their actual law, but we have them think in their mind, this is something, firstly, they don't check. Like, they're not checking at all. Someone else is checking. Like, they are definitely off limits. Because if they start checking, it's checking and checking and checking and checking and checking. So there's a lot of...
But there's also women who take like a day, an entire day to prep.
Yes, and so preparation would be usually most rabbis who we work with will say limit preparation to 30 minutes and no more.
Oh, wow. So that, I mean, I think it's important for college teachers and to kind of be aware of these.
A lot. College teachers these days are pretty savvy to this kind of thing. And by the way, even not with OCD, people still have a lot of hangups when it comes to sex and sexual activity. Some of that is somewhat scrupulous, but I think a lot of it is not necessarily related to it. By the way, religious.
We had Diana Melnick on here.
Oh, good.
Talking,
she's my wife's close friend. So.
Yeah, she was awesome. Well, we weren't allowed to save it, so whoever missed it. But she was amazing. Yeah,
she's cool. So yeah, people have to basically violate their OCD law, and face the music. So let me just see the questions.
So somebody asked, what should you do if you know someone that has OCD but refuses to admit it? And I actually have had a few questions sent in advance that were asking pretty much the same question about family members, like siblings and different family members.
I'll tell you what our office does, which is this. When we often get calls from parents and spouses, sometimes children, but that's less common, who have concerns about the OCD of their loved one. And what we'll do is we won't work with that patient because they are not even willing to admit that they have OCD, let alone come and see somebody. We will work with the family member, though. And the question isn't what can they do. The question is what can you do? And whoever asked this question, you asked it great, which is what should you do if you know someone who has OCD and refuses to admit it? The first thing is to stop accommodating. Most people will continue to accommodate their OCD. I've had parents who the child will not get into the car in the morning. So what they'll do, because they're afraid of the germs, so they don't want to open that car door handle, so they'll open it for them. Or they won't do certain things at night, so the parent will do it. Will always do it for them. They'll accommodate the OCD as opposed to letting the child suffer the consequences. Now I understand, and the same thing with spouses. Now I understand sometimes there's a delicate balance because you can't make a war out of everything in a house, otherwise it becomes intolerable for people. So that's why we will work with that person as opposed to the person who has OCD in order to help them figure out what's the next small step I can take to stop accommodating and how can I move in the right direction. So we've had cases. I had a case of a 24-year-old boy who was living at home. His parents were accommodating him so much. He was literally urinating in bottles in his room.
In bottles?
Mm-hmm. He would not use the restroom, and his parents were so afraid of him. Often people with OCD can develop anger because they don't want to deal with the fallout of not having their OCD. It's something which is only starting to be researched and talked about, is anger as a comorbidity with OCD, and it's a big problem, especially in family units. And sometimes children just have to, have it tough. Like, this is OCD, this is what it is. We love you, but we cannot do that for you anymore. And it's sort of a tough love, and it's necessary. In other cases, though, it's more complicated. So that's why consultation is worthwhile. But if you or a loved one, if you have somebody who's in your family who you love who has OCD, that's off, and they won't admit it, that's time for you to get the help. There's another thing, which is that people often will not admit that they have a problem or acknowledge it when they feel that they can't overcome it. So it's very important not only to be tough with somebody who has OCD, but often to give them hope, to give them a sense that they can overcome it, just a general sense of self-efficacy, greater awareness of the OCD. These are sometimes very important key factors. Okay.
Do you want me to read the next
Yeah,
question?
why don't you moderate the Q&A?
How might ERP look different through telehealth? How can we implement it effectively during this time? I guess it would depend on the nature of the obsessions and compulsions.
Yeah, great question. Telehealth we've used for years, really, in delivering ERP, not only during COVID, but in general. Now it's all the rage, telehealth, right? You can find it everywhere. But even before this, we've used telehealth because it gets you into the person's home. And you can actually see, like, how bad is this OCD? What does it really look like? And you can see what the pots and pans look like that haven't been washed because they're afraid of the contamination, or how much garbage there is, or to what extent they're really avoiding certain things in the morning, or like, hey, what's that on your bed? Well, hold on, you have what? Like, you didn't tell me about that whole compulsion and obsession. And you can really get a ton of information by looking at a person in their natural context. Another thing with ERP, which is great, when you do ERP in an office, it might or might not generalize back to the person's home. But when you do ERP in the person's home, you're golden. So many ways, telehealth is actually great for ERP. It's great. The one thing is that you're not there with the patient, and it's sometimes harder to motivate them, which is a big factor. But as long as you have a good relationship with your patient, they understand the rationale for it, and they're motivated, you can actually get a lot more done.
That's great. Somebody else asked, anger, does that include self-harm?
Yeah, self-harm is more serious. It's not necessary. Self-harm is not necessarily anger. Sometimes it is interpersonally mediated. Sometimes it is not interpersonally mediated. Sometimes, most often, self-harm is a way of regulating one person's emotions. So they're having a lot of intense emotions. What we're seeing a lot more of these days is more borderline personality disorder symptoms, which are comorbid with OCD. My program in New York is one of the, I wouldn't say one of the only ones, but I think we are sort of unique because we have a full service DBT program, and we also treat a ton of patients with anxiety and OCD. So when patients have self-harm and OCD, we're often a good address for that. There are other places that do a great job with OCD, and many places that do a wonderful job with DBT, with the borderline symptoms in delivering dialectical behavior therapy. But I think we're one of the few programs that really does both very well, although there are a couple of others. But I wouldn't assume that self-harm is anger. It's not necessarily anger at someone else, or even anger at oneself. Sometimes people are just doing it because it's the only thing that makes them feel better, or the only thing that stops them from feeling numb. That's a whole other discussion.
Control?
Well, everything's about control, so I guess so.
So somebody else asked, are fear, compulsions, and pure OCD treated the same way?
One more times?
Are fear, compulsions, and pure OCD treated the same way?
Just one more point before we get to that. Someone just mentioned not all self-harmers are borderline. 100% that's correct. Self-harm is a symptom of borderline. Self-harm can occur with or without other symptoms of borderline personality disorder. 100%. There are many patients who, in fact, self-harm is becoming so prevalent. Recent data suggests that up to 20% of college students, I don't mean college kids at counseling centers, I mean just college students in the United States, have engaged in self-harm in the past 12 months. So that's a very important point. Thank you, Mental Health Proactive, for making that.
That sounds alarming.
It is alarming, and that's one of the reasons that my program moved into that space of being able to help. The good news is that we really can help people with self-harm quite quickly. It's actually responds very well, typically, to psychosocial treatment. So that's the good news there. Sorry about that. I interrupted your other question, but I didn't want to let that go.
Oh, that's okay. I actually have a few more questions. I don't know what time it is, but Hmm?
Yeah, I got a couple more minutes.
So I can't read what I wrote. Uh, so that's kind of so how can you tell? Oh, I think you answered this already. And where do you draw the line between OCD and like being a good Jew? I think you kind of addressed that.
Well, they have nothing to do with each other. One is, trying to relate to the sacred, and the other is trying to get rid of thoughts in your mind.
Yeah,
I think
I
that
think you addressed all of the questions.
if somebody can't see the difference between the two, I will say this: if somebody can't see the difference between OCD and religion, either their definition and their understanding of religion is off, or their understanding of OCD is off.
Well, that makes sense based on what you said, like because I think that people who like have a debilitating fear over religion aren't practicing religion, like they don't understand their religion.
They might also practice religion elsewhere in their lives, but those aspects of their religious lives are OCD, not religious. The religion is being co-opted by OCD. It's being taken over by OCD in those areas.
The question was, can pure OCD be also treated with ERP?
Pure OCD? The person's talking about pure obsessions. Pure obsessions is interesting. Pure obsessions are when people have obsessions, but they don't have compulsions. Typically, there's some sort of a mental compulsion that a person's engaging in, but it's all in their mind. It is a lot harder because as a clinician, it's not like you can help the patient to touch something that they don't want to touch or to do something that they don't want to do. It's all here. And like there's only so much, that you can help a person to change their actual mind. But with that said, there definitely are models of it that it can help in most cases. In other cases, though, I will tell you this: pure OCD, people have pure obsessions. They will typically have less insight, and it's important to help them just getting awareness of their OCD. What's a real thought and what's an OCD thought, in of itself is critical. Maybe even more than exposure for such patients.
So just kind of sorting through what's going on in their mind.
Yeah. Is this OCD? Is it not? Oh, it's OCD. Then I probably shouldn't engage with the thought. Move on.
If it was only that easy to just move on from thoughts.
Well, I'm going to move on because I don't have a choice. Otherwise, I'm going to be stuck in my head for the rest of my life.
Somebody said, can you talk about HOCD? I don't know what that
HOCD is probably my favorite thing to talk about. My favorite thing, aspect of OCD. Definitely my favorite OCD symptom to deal with. Do you know what HOCD is, Rebecca?
No.
No? It is homosexual OCD. And these are...
What's that?
What is homosexual OCD? Homosexual OCD is when people have thoughts that they might be gay, and those are dystonic. They don't identify as gay. They don't want to be gay, but they have these nagging, upsetting, distressing thoughts that they might be gay. So they will engage in lots of compulsions.
That's so hard.
It's excruciating. It's excruciating. They will engage in all sorts of, for example, they'll pass by, if they're female, they'll pass by other females and like, did I feel aroused? Did I not feel aroused? Do I think she's pretty? Do I not think she's pretty? Do I think she's prettier than that guy who is attractive to me? Is he attractive? Is she attractive? No, they will.
So then how would they know if they really are or not?
Worse, sometimes it gets really complicated. They'll engage in experimentation. So now what's going on? They're actually engaging in homosexual behavior. Is that because they wanted it? Is it because they didn't want it? Is it because they were testing it out? Like, what's going on here? So what we teach people with HOCD is to completely let go of that obsession.
So
Sometimes
how do
you
they
also,
decipher between the obsession and the
it's going to be
desire?
ambiguous and let it go. Just let it go. Don't focus on it. There's also exposure, which can get really interesting because people are sometimes exposed to either hanging out with like a good looking friend who's of the same gender and they have to like, do I feel attracted? Do I not? You know? And like they just got to let it ride. Or sometimes even worse, there's sometimes other exposures which are more explicit that they're engaging in. And it's the same as any other area. What's nice about HOCD is that even one or two sessions of psychoeducation where we just teach people thoughts about, especially in that area, they're going to be strange sometimes. Sometimes people have thoughts about sexuality. Like, what was that? Like, you just move on with it, as opposed to be like, oh my God, maybe that's who I am. Like, no, like most, healthy human beings will have certain thoughts that pop into their mind about that domain that aren't necessarily reflective of who they are or what they want. That's just a thought that just popped up. As we say, a thought is just. So thanks for asking me. What do I suggest people to let it go? How can they? So I kind of answered that question right now. The nature of the thoughts, especially in that area, is a lot less important than what a person really wants to do.
So usually they would probably feel like guilt or like shame cycles, and that would be what's like driving the whole thing.
What? Shame, right?
So if they could just kind of, if they just kind of let go, and like I understand what you're saying about the let go, even though it could be like, as a few people just said, it's easier said than done to just let go.
It is, but once a person realizes, once a patient realizes that the thoughts aren't worth thinking about, that's the first step. You're right, it's easier said than done, but if you go, then it's impossible. The first step in OCD is, these are OCD thoughts, I'm not going to talk about them, and I'm going to walk the other way. But if you don't know to walk the other way, you're going to get stuck in them your whole life.
Well, I guess it's kind of like if somebody has a fear of death, and you just kind of say, like, yeah, you are going to die at some point. Then
yeah.
They could let it go.
Right. Another thing is, I say to patients, like, if you're gay, maybe you're not. What do you want to do? Who do you want to date?
Okay, there's been a bunch of, so easier said than done. How's it an answer to let it go? You said that, you answered that already. What happens after treating someone with OCD for months and they don't get better? For example, with what you're saying, sometimes education and ERP won't solve the problem. People can find comfort in their obsessions, especially if they struggle with comorbid symptoms.
No. Sometimes people aren't ready to. Sometimes people aren't ready to fully engage in ERP. Sometimes there are other factors, like a person's too depressed to engage in it, or they're not fully motivated. Other times they're not fully aware of their OCD, the extent of it, and how it's bothering them. And there are cases where ERP, doesn't work for some people. So I wouldn't give up. I mean, I think sometimes people, have to cope with difficult situations for years or even decades before things get better. But, I do believe, like, ultimately, there are opportunities that present themselves. We just sometimes have to take a longer term approach. I've definitely had some patients who did not respond well to ERP. Usually it's because they're not fully doing it. But sometimes it's extremely difficult. Sometimes they're carrying around OCD, their parents had OCD, their grandparents had OCD, multi-generational already, and it's all falling on them and very challenging for them. So there are situations like that, and I think it's important to recognize and to have a lot of compassion for our patients.
So somebody else said, you have to be willing to live with uncertainty.
True. That's actually.
Somebody else said, Someone else said, why would they then